Dr. Ray. No problem. Thank you for joining us. Just reminding everybody before you start speaking that they have been placed in listen-only mode, so that if they have questions during the presentation, to please submit them via the Q&A portion of the WebEx so that we can address them as time allows at the end of the event. And as always, you can find slides from the webinar as well as a recording of the event on our provider webpage. On our website, we will provide that link at the end of the webinar in the slides as well, and you should see that by tomorrow afternoon. We also thank you for your participation in a brief poll that we will be issuing in the last 5 or 10 minutes of the event. And today we have a really interesting presentation about monoclonal antibodies for treatment and prevention of COVID-19 in New York City. We're joined by colleagues from the Health Department as well as representatives from the Greater New York Hospital Association. So with that, I will hand it off to Dr. Ray.
Thank you, Allison. And can we advance the slide, please? And I think it's just a quick reminder to make sure that you collect your continuing medical education for attending this presentation. And today we have several updates on the latest epidemiology, featuring some new and really exciting data visualizations from our data website, which we can put the link to in the chat in a few minutes. Additionally, the updates and guidance, especially around vaccination, are rapidly evolving. And so I have a collection of updates for you. And then, of course, our very, very exciting presentation on monoclonal antibodies for treatment and prevention of COVID in New York City. And then, of course, we are going to try to leave time for your questions and for a panel discussion. And can you advance the slide, please? All right, so as usual, we'll just recap the current status of the COVID-19 pandemic. Worldwide, we have exceeded 100 million cases, and we're over even 110 million. We're almost at 2.5 million deaths. So we have seen throughout this year, especially since the beginning of 2021, we've seen an increase to where many countries are at their highest level of COVID. They're reporting the highest number of cases. And overall, the numbers in general for many, many countries are stabilizing and slowly starting to decrease. Of course, the numbers of new cases are not in a safe place. It's not a time to say that everything has been resolved, but it is a little bit hopeful that, the trend we had seen previously where the transmission was worsening worldwide is slowly changing. In the U.S., where the situation was similar, we have over 28 million cases with over 500,000 deaths. And similarly, the case counts have declined for the past 5 weeks, meaning that the rate of increase in COVID cases has slowed down. It's almost like the acceleration of COVID transmission has slowed down, but there are still, as we're seeing, significant numbers of new cases every day. Similarly, we always see a delayed trend in hospitalizations and deaths from reported cases, but those are also starting to decrease nationwide. And just as a reminder, daily counts in the U.S. are higher than seen during the peak of the highest wave that the U.S. previously experienced, which was in summer 2020. So, of course, it is still a time for to be extra careful about all the precautions, to make sure your patients are aware that the precautions are still critical and there's still significant individual risk due to COVID, but there is a little ray of hope. In New York City specifically, again, the trend continues all the way down at the city level. We have almost 600,000 cases cumulatively in New York City, over 23,000 confirmed deaths, and just as we have reported everywhere else, the numbers of new cases every day are declining, so they're no longer going up, and an increased number of new cases every day, as we saw earlier in the year. Similarly, hospitalizations and deaths have stabilized, and if the hospitalizations and deaths follow the trend in cases, then we can expect some decrease in them in the coming weeks. And can you advance the slide, please? So here we just have a visualization of what I was just describing with regard to the new number of cases. And of course, we do see patterns in testing where there's often decreased health-seeking behavior on weekends, sometimes on holidays, and so that's why you'll see you'll see some variation and some dips in the number of cases reported here. But this line, this dark blue line, shows a 7-day average. And of course, the most recent data, which is represented in the gray bar on the graph, are incomplete. And, it sometimes takes us some time to receive reported data from tests. And so we don't want to use those exact numbers, but we can see that, you can see that the peak in 2021, the peak average was over 6,000, and our last 7-day average with the complete data are 4,600 new cases per day. So you can see a pretty consistent decrease, and then, of course, maybe a dip here due to the snowstorm. As always, on this graph, we represent those probable cases, which are, people who have presumed COVID, who have a positive antigen test, because the antigen tests are sometimes, rapid antigen tests are sometimes less reliable than PCR tests, and of course people who died and had COVID listed on their death certificate but did not have a positive laboratory test associated with that. And so you can see that there's a pretty solid chunk that continues to be from antigen tests. And can you advance the slide, please? So hospitalizations, as I mentioned, do tend to lag a little behind cases, and so we saw high numbers in the cases, and then we have started to see a decrease in them. And for hospitalizations, we are at a plateau. Again, in the gray bar, those data are incomplete, but our last 7-day average for COVID-19 hospitalizations in New York City was about 370 per day, which you can see represents kind of a plateau after a steady increase that's been occurring through the end of last year. And can you advance the slide, please? Deaths, again, deaths, if anything, lag behind hospitalizations, and we see a similar pattern here where, again, you're seeing that slope on the hospitalizations that we saw earlier in the cases, where we saw that increase in slope. Now that's a little bit delayed for the deaths, but we are starting to see an early stabilization in the number of deaths. And these numbers include, in light gray, the number of confirmed deaths. Dark gray at the bottom are the number of probable deaths, which of course require investigation, and so the most recent data have a lot of probable deaths before they are confirmed. The last 7-day average was about 80 deaths, which includes both confirmed and probable, per day. And can you advance the slide, please? And so the next topic is something that I think all of you are very interested in, which is the rapidly evolving COVID-19 vaccine updates across the United States. And at this point, approximately 12%, that's a little less than 1/8 of the U.S. population, has received at least one dose of the COVID-19 vaccine. And as I'm sure all of you are aware, the supply of vaccine, and in many jurisdictions and states, has often been a rate limiting factor in how many persons are vaccinated. But with increased supply, with continuing operational improvements, the pace of vaccination has increased in the recent weeks. However, although the overall pace of vaccination has increased, in the current week, the severe winter storms that we are seeing across the country have significantly slowed or delayed or temporarily stopped the distribution of vaccine, and that includes in New York City. There are also several federal policies aimed at increasing access to vaccination, and this includes a federal retail pharmacy distribution program, and of course the weekly allocations there are increasing as pharmacies are able to accept and move that vaccine. Similarly, a new federal program is going to supply vaccine directly to federally qualified health centers, including many of those in New York City. And which is really exciting, a very, very exciting piece of news, is that the Biden administration announced having secured a sufficient vaccine supply for the whole adult population of persons living and working in the United States, which is of course a significant step in providing, in achieving widespread vaccination and achieving widespread availability of vaccination. Of course, the distribution and administration of vaccination is the next step that we have to think about. Another piece of great news is that the FDA is going to review the emergency use authorization for the Johnson & Johnson COVID-19 vaccine candidate. And, we can certainly talk about that vaccine in the questions, but that vaccine is a one-dose vaccine, and the logistics of its transportation are relatively simple. And so that is an exciting, that'll be an exciting aspect of COVID-19 supply and distribution. And finally, the FDA amended the emergency use authorization for the Pfizer Bio-Entec vaccine to reflect 6 doses per vial, meaning that the allotted doses were listed as 5, but it is standard enough to get 6 doses out of the vial, and that will affect the way that that vaccine ordering takes place, because now it will be in units of 6, and the increments for ordering vaccine in the New York City citywide immunization registry were changed accordingly. There is, it is always possible, as in any multi-dose vial any multi-dose vial administration, it is possible that some persons drawing may not obtain the full 6 doses, and there is an option within the citywide immunization registry to report this, and the slides will be available, but there is information for all providers on the CIR, and there are instructions on how to obtain registry with the CIR at the website listed at the bottom of the page. And can you advance the slide, please? So you may also have heard that the CDC updated clinical considerations for the 2 currently authorized COVID-19 vaccines, the Pfizer BioNTech and Moderna vaccines. There has been a lot of conversation about severe allergy with these vaccines, and the contraindications and precautions related to allergy and related to many other topics are clarified in this guidance. Specifically regarding the allergy, the guidance is persons with a reaction to vaccine or injectable therapy containing multiple components, one of which is also an mRNA COVID-19 vaccine component, but for whom it is unknown which component caused the immediate allergic reaction have a precaution to vaccination. And so this clarifies the previous guidance that, perhaps injectable, a severe reaction to any injectable therapy or vaccine would put you under precaution for this vaccine. At this point, it has to be, specifically a component of the mRNA COVID vaccine, and, or if there's a suspicion of it, if you couldn't identify the particular agent causing the allergic reaction. Similarly, information on delayed local injection site reactions after the first dose has been updated. Delayed onset local injection site reactions, sometimes described as a COVID rash that many of you have seen in your patients after administration, or of course, there's always with any injection a small risk of infection at the site. The beginning a few days through the second week after administration of the first vaccine dose have been reported. It is important to note that while this is a reaction to the vaccine administration, it is not felt to be a risk for anaphylaxis. It is neither a contraindication nor a precaution to the second dose. And so in most cases, those persons who develop this reaction should still schedule and receive their second dose. And of course, there is additional clarity on preventing, reporting, and managing vaccine administration errors. And can you advance the slide, please? The CDC has also issued updated recommendations for vaccinated persons, fully vaccinated persons, that is, with an exposure to COVID-19. So these, generally, if a person is exposed to someone with COVID-19, in most cases, that person would be asked to quarantine for a period of time, usually 10 days if they're asymptomatic. So at this point, the CDC has tried to balance what we know about the benefits that full vaccination provides with some of the data that we are unaware, or that we do not have a complete understanding of. And so specifically, if a person is fully vaccinated, meaning that if they have received a complete series of vaccines and 2 weeks has passed since the completion of the series, meaning that they had some time to build immunity, and it has been less than 3 months following that last dose, and the person is asymptomatic, does not have any symptoms of COVID, at that point, most people will be exempt from quarantine. This guidance aligns, aligns vaccine-provided immunity with some of the recommendations around natural immunity, where there is a precautionary suspicion that immunity may not be as strong after 3 months, that that requires further investigation. Now, the exceptions to this exemption from quarantine include inpatients and residents in healthcare settings, given increased risks of exposing others. Persons who are inpatients or residents in healthcare settings do have to quarantine if they have any exposure to COVID-19, even if they are fully vaccinated. We can talk about the guidance for healthcare workers if you are interested in the chat after the talk. The important part about this guidance, though, is that the recommendations have not yet been officially adopted in New York State, although the governor has announced an intent to make this guidance part of New York State policy. So look for that policy to be released in the coming days and weeks. And can you advance the slide, please? So we have a couple of updates around the COVID-19 vaccine campaign. So as I'm sure all of you are aware, that starting this past Monday, February 15th, people with specified underlying conditions or who are pregnant are eligible to receive vaccination in New York State. This is, of course, the policy within several sites in New York City as well. So if the vaccine provider has access to the medical record, if the provider has records showing the person has an eligible condition, that is sufficient for proof of eligibility. Otherwise, an attestation form is required. Initially, there was some suspicion, there was some chatter that vaccine recipients would have to provide lab tests, documentation from a provider that they do in fact have this underlying condition. That is not true. So persons receiving the vaccine or who are eligible because of the existence of their underlying condition do not need to obtain that documentation. There's a link here to the attestation form, which we can copy into the chat. And then, of course, the specific conditions that the underlying medical conditions that provide eligibility are listed on our vaccine distribution website, and those guidances those lists are constantly being updated as soon as we have an update in policy. So I encourage you to check that frequently at nyc.gov/COVID vaccine distribution. Many of you are also quite concerned about our plan to vaccinate older adults. So, of course, older adults became eligible for vaccination in January. Persons 65 and older, solely based on age, are eligible for vaccination. And New York City has launched several senior vaccination clinics at retirement communities and senior buildings this week. There is a specific focused effort to vaccinate health aides and other caregivers for seniors. And, given the complexity of the logistics of in-home vaccination, we are actively planning for an in-home vaccination program, and this will be likely to be implemented when the Johnson & Johnson vaccine becomes available, given the decreased complexity of its storage requirements. And can you advance the slide, please? So, as we mentioned earlier, the administration of vaccine is progressing very quickly in New York City, even if it is not as quickly as we like due to supply constraints and weather constraints. But almost 1.5 million doses of the vaccine, including both first dose and second dose, have been administered. 850,000 dose ones have been administered, meaning that 850,000 persons in New York City are at least partially vaccinated. Over 400,000 persons have received their second dose and have completed the series through New York City run programs. And then federal pharmacy programs are also distributing vaccine, and they have administered just under 150,000 doses. And can you advance the slide, please? Many of you may remember a letter and health alert that we issued previously, really encouraging the completion of race and ethnicity data. We have also worked with other health systems and other organizations administering vaccine to stress the importance of collection of race and ethnicity data. And so the completion of race and ethnicity data has improved from 60% to 72% of vaccinations that have race and have a known race and ethnicity associated with them, and so we can get a stronger picture of how uptake is occurring amongst different races and ethnicities. We similarly have data by sex, and we have data by age group, and data by borough of residence. And I encourage you to check these out and look at how the different distributions into different categories are relative to each other. And of course, it's always important when thinking about these numbers to think about the impacts of COVID. So the number of cases, the number of hospitalizations, and the number of deaths, because that'll give you context to think about the number of those that could potentially be prevented through vaccination. And can you advance the slide, please? So as was indicated by the other slide, the vaccination rates per population are not equal around New York City. And so you can see that in many areas of the city, the rate per population is much lower. The percentages go all the way from 0 to 27%. And of course, the first dose per population percentages are higher than the second dose or the full vaccination status. I think that the fact that the first dose numbers contain bright areas in more, or dark areas in more portions of the city do indicate an improvement in the equitable distribution of the vaccine, but we will have to keep following these data very closely. And can you advance the slide, please? Another topic that there are many questions about is the emerging SARS-CoV-2 variants. So, the variants are often named by the location they're discovered in, but we actually prefer to use a scientific name for them so as not to penalize the country that discovered the variant for their discovery, for their scientific discoveries. So the B117 variant is one of the first variants that became popular, and several cases of this variant have been identified in New York City to date, including cases of this variant that don't have a clear exposure outside of the United States, and thus may have contracted it within communities in New York City. This is what's sometimes known as the UK variant. It emerged in the UK at the end of last year, and it does appear to be approximately 50% more infectious than other common variants. There are some indications that it may be associated with a higher risk of hospitalization and death, and of course that has to be parsed out with the state of the healthcare system at the time. The number of cases identified in the U.S. is increasing pretty rapidly. It's doubling about every 10 days. The B1351 variant was first identified in South Africa at the end of the year, and there have been several cases identified in the U.S. to date, none in New York City, but one was identified, or none that in New York City residents, but one case was identified in a Connecticut resident who was hospitalized in New York City. Finally, the P1 variant you may have heard about emerged in Brazil, and that was, we first started hearing about it in January of 2021. It has been identified in the U.S. It was first identified in the U.S. At the end of January. It has not yet been identified in New York City. And we're happy to talk about this in the questions, but what does this mean? What does the existence variants mean? What does it mean for antibodies? What does it mean for vaccination? And of course, we are still learning much of that information. And of course, the information we learn now may be different for other variants that emerge. However, the preliminary studies suggest that several of the currently available vaccines, including Bio-Entec and Moderna, may have decreased efficacy against one of these variants, which is the B117 variant. However, studies do suggest that the vaccines are still effective. So decreased efficacy, but the antibodies generated will still recognize the variants. We will have more updates for you as we learn more. And just as a reminder, even if the vaccine does not have efficacy against a variant, strain-specific boosters are something that is under investigation and something that is relatively, I would say, relative to developing a whole new vaccine, is relatively much easier for companies to develop and to produce. So, we'll look forward to learning more about that in the coming weeks. And can you advance the slide, please? So additionally, another new update is that there is updated CDC guidance on the use of masks to prevent SARS-CoV-2 transmission and exposure. And these are actually experimentally assessed. Specifically, they assessed reevaluated fitting a cloth mask over a medical procedure mask and knotting ear loops of medical procedure mask and tucking the extra material close to the face. So both of these experimental procedures, or these experimental strategies, improved the fit of the mask, and both improved source control and also reduced wearer exposure. And so the implication is, of course, that the close fit is really critical to preventing the spread of COVID. And they saw the greatest impact amongst all the tests when the infected person and the uninfected contact use tightly fitted masks. CDC has updated its guidance. And can you advance the slide, please? There is updated New York City guidance. There's updated New York City guidance for the public on face coverings. I encourage you to check it out on our website. And of course, it emphasizes the importance of a snug fit. It provides specific guidance on different types of face coverings, the optional use of 2 face coverings or higher grade masks. And it really just stresses that every time you leave home, at home when a household member is ill or exposed, when receiving visitors, these are all situations where it is important to wear that face covering. And can you advance the slide, please? So for this week's Making History section, we're going to highlight the work of community partners who are serving communities that have been disproportionately impacted by COVID-19. And these are communities that have experienced high case rates of COVID-19, high mortality, the presence of overcrowded housing, which is a risk, high numbers of individuals experiencing poverty and other health disparities. These are also very closely related to centuries of underinvestment, disinvestment, racist policies and practices, inadequate housing and public infrastructure, unequal access to resources and power. And of course, these all combine to create a cumulative risk, increased risk of exposure and worse COVID outcomes. So as part of the city's COVID-19 work, we contract with community partners through the Test and Trace program to support equitable access to COVID information, resources, services that is specifically tailored to these communities that have been highly impacted. So in this slide, you can see information about the Rosholo Community Health Center. So under the leadership of Al Tuitt and Lenora Seeley, This unit at the Rosholo Community Health Center has been working with youth teams in the Bronx to reach and engage with community members. Over the past several months, they have canvassed nature developments, developed public service announcements, responded to increased food insecurity by distributing bags of food, and built a network of support for hundreds of families. All of this leveraged local connections with food pantries, faith-based leaders, and local businesses. The COVID-19 related work builds on the center's work of serving more than 35,000 preschoolers, school-aged children, teens, adults, and older adults through support, enrichment, education, and recreation programs, and expanding, in general, the opportunities to live full, productive lives. And so this partner organization, its youth team, are our COVID-19 heroes, and you can check out the slides after the presentation for a lot of the detailed information. Advance the slide, please. Another organization that has been helping us reach community members during this pandemic is Housing Works. Here we're highlighting its Youth Prevention Services Program, which is coordinated by Susan Zhou. Her quote, which is listed on the site, or on the slide, which you can check out later, really shares how much the impact is felt right away. The Youth Prevention Services Program uses peer-to-peer model, leads outreach and engagement activities, and distributes information and PPE to its networks. Peers conduct street outreach and distribute COVID-19 information, face coverings, and sanitizer in targeted areas where community members naturally congregate, including waterfronts, busy intersections, subway stops, and public parks and recreation spaces. COVID-19 related work builds on the tremendous commitment of Housing Works to advocate for and provide comprehensive services to over 30,000 homeless and low-income New Yorkers living with HIV/AIDS or at risk of infection. These services include housing, job training, legal assistance, and comprehensive health care. It is also funded through Test and Trace to educate community members through internal and external partnerships. Housing Works partners with a range of community groups serving target populations, including Black, Latino, LGBTQI+, and CGNC/CNV communities, individuals who are homeless or experiencing housing instability, individuals with behavioral health needs, justice-involved individuals, and individuals who use drugs or substances, individuals with informal jobs, and individuals with informal job situations, including sex workers. And at this point, I'm going to pass the slides over to my colleagues to talk about monoclonal antibodies for treatment and prevention.
Good afternoon. My name is Theodore Seyum, and today I'm going to be talking about the monoclonal antibodies for treatment and prevention of COVID-19 in New York City. Next slide, please. Here's an outline for today's talk. First, an introduction and a brief description of monoclonal antibodies. Then I will talk about FDA-authorized monoclonal antibody therapeutics available for use, the scientific evidence behind the authorization, who is eligible to receive these treatments, and the safety profile of these products. Next, I'll provide information on how to access these treatments. And I'll finish off with a discussion for the need of an equitable allocation of treatment in our population. Next slide, please. So the COVID-19 pandemic has claimed almost 500,000 lives. High-risk patients are especially vulnerable to developing severe COVID-19, and some patients with mild to moderate COVID-19 infection even suffer from long-term symptoms long after they recover from the disease. So stopping the progression of the disease after initial infection could help to prevent suffering, death, and the long-term sequelae of COVID-19 infection. So there is a need for an early outpatient treatment of patients infected with COVID-19 to prevent or lessen severity of the disease. There have been several treatment modalities that have been granted EUAs and are indicated for hospitalized patients with severe COVID-19. Including remdesivir, dexamethasone, and convalescent plasma from previously infected patients. Monoclonal antibodies, however, have been granted an EUA for use in the outpatient setting for patients at high risk for severe COVID-19. Mass vaccination of the general population will take time. Monoclonal antibody treatment may be used in outpatient settings as an interim strategy to decrease the severity of infection, reduce human costs, and reduce overall stress on the healthcare system. The U.S. DHHS has established the Special Projects for Equitable and Efficient Distribution, also known as the SPEED program, which supports direct allocation of monoclonal antibody therapeutics to outpatient facilities. I just want to stress that although multiple treatments have been investigated, monoclonal antibodies are the only outpatient option shown to be effective and beneficial to patients. Next slide, please. And here is a nice schematic that highlights the fact that all of the therapeutics developed so far, including antiviral therapies and immune modulators, have been for COVID patients that are sick enough to be hospitalized or require ICU admission. The advantage of monoclonal antibody treatment is to catch patients with a COVID diagnosis early enough to prevent disease progression and provide treatment as an outpatient, thus preventing ED visits, hospitalizations, and ICU admission. There are no pre-exposure prophylaxis therapies authorized for use at this time. For further information regarding treatment guidelines, visit the NIH website at the bottom of the slide. Next slide, please. Early in the pandemic, convalescent plasma was granted an EUA to be used as a therapeutic option. Convalescent plasma consists of a variety of antibodies against various viral targets and comes from a polyclonal immune response already present in the plasma of patients who have recovered from an infection. Convalescent plasma is easier to obtain than monoclonal antibodies, and the composition is also different. Monoclonal antibodies are laboratory-produced molecules engineered to serve as substitute antibodies against a specific target of a pathogen. In effect, monoclonal antibodies enhance or mimic the natural immune system's response to a pathogen such as SARS-CoV. Monoclonal antibodies are developed by isolating and expressing antibody genes from B cells derived from convalescent patients who have already recovered from infection. These genes express strong neutralizing antibodies against the target on a specific pathogen. For the SARS-CoV-2 virus, monoclonal antibodies currently under development target the SARS-CoV-2 spike protein, which this virus utilizes to enter the host cells. Next slide. So there are 3 monoclonal antibody products that have been granted EUA status for treating mild to moderate COVID-19 in the outpatient setting. All of these products target different regions of the spike protein of SARS-CoV-2. Bamlanivimab and etesevimab were developed by Eli Lilly Pharmaceuticals. They were identified from 2 convalescent patients in North America and China, respectively, and are directed against 2 different regions of the SARS-CoV-2 spike protein receptor binding domain. Bamlanivimab can also be used as a monotherapy or in combination with etesevimab as a cocktail. Casirivimab and imdemimab, also known as Regeneron, were developed by Regeneron Pharmaceuticals. They are a cocktail of 2 recombinant monoclonal antibodies that also bind to different regions of the SARS-CoV-2 spike protein receptor binding domain. Bamlanivimab is only authorized for use at the 700 milligram dose alone or in combination with 1,400 milligrams of etesevimab. Casirivimab and imdemimab are only authorized at 1,200 milligrams each. And the optimal dosing regimen for both agents has not been established and studies are ongoing. The bamlanivimab and etesevimab cocktail were granted the EUA less than 2 weeks ago and is not available for use at this time. The EUA for these agents requires that they are used in outpatients only via a one-time intravenous infusion, administered after a positive viral test for SARS-CoV-2, either a PCR or an antigen test, and must be given within 10 days of symptom onset. Next slide. Now, some of the scientific evidence. There are 3 ongoing clinical trials for bamlanivimab and etesevimab that are in different phases. The current EUA for outpatient use was based on the phase 2 BLAZE-1 trial. An interim analysis looked at 465 non-hospitalized adult patients with mild to moderate COVID-19 at 29 days after enrollment. The results showed that viral load cleared in all patients on day 11 in both the treatment and placebo arms. Now, when you look at tables on the right, only 2% of participants in the treatment group were hospitalized or required an ED visit versus 6% in the placebo group, as shown on the top table. Now, in patients at higher risk for complications, only 3% from the treatment group required an ED visit versus 10% in the placebo group, as shown in the bottom table. The time to symptom improvement was reduced from 8 days in the placebo group to 6 days in the treatment group. Now, the second study is the phase 3 BLAZE-2 prevention trial, which included 132 participants who tested positive for the virus at baseline and thus did not qualify for the prevention trial. 41 out of the 132 were nursing home residents. These residents were assigned to a treatment and a placebo group. Of the 41 nursing home residents who obtained a COVID-19 diagnosis, there were 4 COVID-related deaths, all in the placebo arm. Now, this information was obtained from an Eli Lilly press release. The trial is still ongoing, and bamlanivimab has not been authorized for use in the prevention of COVID-19. Next slide. Now, the phase 2 BLAZE-1 trial also looked at a monoclonal antibody cocktail of bamlanivimab and etesevimab for treating mild to moderate COVID-19 infection. This is a continuation of the trial I talked about in the previous slide, with subsequent analysis performed with a focus on this cocktail. The final analysis for this phase 2 study compared 5 cohorts, including 3 different doses of bamlanivimab monotherapy, bamlanivimab and etesevimab cocktail at 2,800 milligrams each, and placebo, with the primary endpoint being a change in viral load by day 11. The results showed that compared with placebo, differences in change in viral load at day 11 was not significant for bamlanivimab monotherapy, but there was a significant change in viral load in those who received bamlanivimab etesevimab cocktail. A secondary outcome that was measured in this trial that may be more significant for patients is looking at hospitalizations and ED visits. The placebo arm had the highest number of events at 9, which is 5.8% of the patients. In the treatment arms, rates for bamlanivimab 700 milligrams and bamlanivimab and etesevimab at 2,800 milligrams each had 1 event, which is a 1% rate, while bamlanivimab 2,800 milligrams and bamlanivimab 7,000 milligrams had 2 events each, which is a 2% rate. There were no deaths. Out of all these cohorts, the bamlanivimab etesevimab cocktail was the only significant outcome. Further ongoing clinical trials will focus on assessing the clinical benefit of anti-spike neutralizing antibodies in patients with COVID-19 as the primary endpoint. Next slide, please. Another trial I want to talk about is the phase 3 BLAZE-1 trial. It looked at a different dosage than the EUA-approved combination for the bamlanivimab and etesevimab cocktail for treating mild to moderate COVID-19 infection in high-risk outpatients. This trial looked at 1,035 patients within 3 days of a positive SARS-CoV-2 test and were randomized to receive bamlanivimab, etesevimab at 2,800 milligrams each or placebo. About 1/3 of the study population included patients 65 and older, and the mean BMI was 33 to 34. The mean duration of symptoms was around 4.2 days. Interim analysis showed a 70% risk reduction in hospitalizations and deaths. There were 10 deaths in the placebo group, but none in the treatment group. Viral load was reduced at day 7 with improved symptoms. This information is not published yet and was obtained from an Eli Lilly press release. You can access the link below for details. Next slide. Now, the general cocktail of casirivimab and imdevimab received an EUA based on phase 1 and 2 clinical trials, which included 799 non-hospitalized adults with mild to moderate COVID-19 infection. These patients were followed for at least 29 days. An interim analysis of the first 275 patients showed treatment with the cocktail reduced the viral load from day 1 through day 7, with the largest reduction occurring in those who have had viral loads at baseline, of those who had higher viral loads at baseline. Additionally, there was a twofold reduction in medical visits and hospitalization in the treatment group versus the placebo groups. Furthermore, there was a threefold reduction in those with higher risk of complications. As far as the median time of symptom improvement, there was only a difference of 1 day between the treatment group at 5 days and 6 days in the placebo group. Next slide, please. Both bamlanivimab and the Regeneron cocktail are being studied in a prevention trial in uninfected subjects exposed to COVID-19. These studies are being conducted in nursing homes and households with infected individuals. During the phase 3 BLAZE-2 prevention trial with bamlanivimab, 965 nursing home residents and staff were enrolled to assess prevention of infection. In a press release by Eli Lilly, 299 nursing home residents randomized to bamlanivimab had 80% lower risk of contracting symptomatic COVID-19 when compared to those receiving placebo. The affected nursing home residents were substantially better than in the staff in this interim analysis. Similarly, Regeneron's cocktail is being investigated in a phase 3 study for prevention in COVID-19 in people at high risk of infection due to household exposure to a COVID-19 patient. The interim analysis of the first 400 enrolled participants showed 100% prevention of symptomatic infection and approximately 50% lower overall rates of infection in both symptomatic and asymptomatic COVID-19. Full data is expected early in the second quarter of 2021. Of note, in this trial, the treatment was given subcutaneously or intramuscularly rather than an IV infusion, which would greatly simplify treatment delivery. Next slide. So who is eligible? Monoclonal antibodies are authorized for the treatment of patients who have mild to moderate COVID symptoms, have a positive direct SARS-CoV-2 viral test, either a PCR or an antigen test, are 12 years of age or older, weigh at least 88 pounds, and are at high risk of progressing to severe COVID-19 or hospitalization. Next slide. So this is eligibility criteria that's found in the EUA, and I will actually have you look at it in your own time, just to save more time. Next slide. Okay. Under the EUA, these monoclonal antibodies are only approved for outpatient use. The benefit of treatment with both agents has not been observed in patients hospitalized due to COVID-19. Furthermore, these agents are not authorized for use in patients who require oxygen therapy due to COVID-19 or those who receive chronic oxygen therapy due to an underlying comorbidity and require an increase in baseline oxygen due to COVID-19. However, if patients are already hospitalized for a different reason and are diagnosed with mild to moderate COVID symptoms and meet the criteria listed in the EUA, they are eligible to receive treatment while hospitalized. Next slide. So there have been some reported adverse effects with the most being mild and non-life-threatening. The most common adverse effect is nausea and other infusion-related reactions. Some anaphylaxis and serious infusion-related reactions have been observed, but all reactions resolved after stopping the treatment infusion and treating the subject adequately. So when a patient receives monoclonal antibody treatment, they should be observed for at least 1 hour after completing infusion. And providers should be prepared to respond to any anaphylaxis or serious infusion-related reaction. Adverse effects that are potentially associated with monoclonal antibody treatment need to be reported to the FDA. Next slide. Now, access to monoclonal antibodies. How do we get these? The U.S. Department of Health and Human Services Operation Warp Speed has established a program that will ensure equitable distribution of monoclonal antibodies. This is achieved either through the states or the newly established SPEED program that I mentioned, earlier, which supports direct allocation of monoclonal antibody therapeutics to outpatient facilities that care for high-risk patients. This program prioritizes settings such as long-term facilities, dialysis centers, federally qualified health centers, and correctional facilities. And the most important part is that these treatments are provided at no cost to providers. You can refer to the link on the bottom of the slide for more information. Next slide. Now, for patient referral, there are a few sources to find out where to refer patients for treatment. The Greater New York Hospital Association has a website, which is listed here, which is continuously updated as new sites are added. If time permits, I think we may do a demonstration of this website. The other option is the New York City Health and Hospitals Corporation and has a couple ways to find out treatment sites, either via the website shown here or the phone number. A provider will interview the patient and determine if they're eligible. Also, if the patient was not tested in the H&H system, they will need to bring proof of the positive test before getting treatment. H&H is also a good option for those patients that are uninsured. The last link on the slide is the DHHS's information webpage if you're interested in becoming a treatment site. There are more details in the Dear Colleague letter that you can look at. Next slide. It is essential to understand that starting treatment early will get the best outcomes. We recommend establishing processes to expedite testing and eligibility screening for high-risk symptomatic patients. It is important to have a quick turnaround between when an eligible patient is tested for COVID-19, identified as positive, and scheduled for monoclonal antibody treatment via IV infusion. Eligible patients should be made aware of this treatment option when they present for testing so that if they test positive, they will already have the information to make a decision about whether to accept the therapy. It is optimal to provide monoclonal antibody treatment in the early stages of COVID-19 disease when a person is just starting to experience symptom progression. Ideally, treatment should start as soon as possible after a patient has a confirmed positive test and is exhibiting mild to moderate symptoms. Treatment should also be given within 10 days of symptom onset. Next slide. And finally, a note about equity. Many of New York City's lower income and communities of color have suffered from the highest rates of COVID-19 infections, hospitalizations, and deaths over the course of this pandemic. The disproportionate impact of COVID on Black and Latino New Yorkers is now also being compounded by low vaccination rates among these populations. Mass vaccinations of the general population will likely take many months to achieve, which further underscores the need for effective bridging interventions that can mitigate severity of disease in the most vulnerable patients. Given these challenges, monoclonal antibodies are a potentially life-saving therapy that should be prioritized for eligible Black and Latino patients and others known to have less access to health care and poorer health outcomes, such as indigenous, immigrant, and uninsured populations, including patients that face language barriers. Any eligible patient should get the opportunity to receive treatment regardless of their ability to pay for it. There are several frameworks that could ensure that these patients receive equitable access to monoclonal antibody therapies. I would encourage you to refer to the documents linked in your Dear Colleague letter to ensure that these vulnerable populations get these life-saving treatments. Next slide. In conclusion, the advent of monoclonal antibodies as outpatient therapeutics for the treatment of mild to moderate COVID-19 adds an additional tool to the arsenal for combating the COVID-19 pandemic. Robust uptake by healthcare facilities and administration of these monoclonal antibodies to high-risk patients is of paramount importance, especially in communities of color and low-income neighborhoods. Early treatment with these therapeutics has better outcomes in terms of preventing progression to severe COVID-19, hospitalizations, death, and long-term sequelae of the disease. I just want to highlight that these are investigational products and clinical studies continue under their respective EUAs. Future data will shed further light on the definitive clinical benefit of these treatments. The data collected so far support the potential benefits of these products in reducing hospitalization and need for medical assistance in patients at high risk for complications from COVID-19, and therefore the use should be strongly considered in helping these vulnerable populations. Thank you.
Thank you very much for the presentation. Oh, sorry. There are more resources available for those who are able to access the slides on our website after the webinar. And for those, we understand that it is now past 2 p.m., but for those who are able to stay with us, we also do want to offer just a brief demo from the Greater New York Hospital Association of the website where you can access the tool. So I'm going to pass this over to Faiza Haque from the Greater New York Hospital Association. Apologies if I just butchered your name. And thanks to those who can stay with us. For those who can't, you also will be able to find this recording on our website tomorrow, and you will be able to access this at that time. Thank you.
Hi, thank you so much. Good afternoon, everyone. Thanks for those who can stay on past 2. So my name is Faiza Haque. I'm an assistant director at the Greater New York Hospital Association, and I just wanted to take a few minutes today to talk about a new resource that is available for both patients and providers. So for some quick background, my colleagues at Greater New York and I have been working with the city around efforts to increase awareness around the monoclonal antibody therapeutic treatments. And we've been working to compile important information for the various sites across the downstate New York region that are offering these treatments, including important contact information and their referral processes. So I'm pleased to announce that earlier today, we launched an online resource directory containing this information on HITE, which stands for Health Information Tool for Empowerment. And HITE is Greater New York's public directory of free and low-cost community resources in New York City, Long Island, and Westchester. And we utilize HITE to help our members and other users address health and social services needs in the communities they serve. So at this time, I wanted to share my screen and go over to the HITE website. Okay, so hopefully everyone can see that. All right, so this is the homepage for HITE, which is hitesite.org, and we'll make sure that everyone receives the direct link to the monoclonal antibody directory. So on the top banner, you'll see that there's an option to hover over COVID-19, and so this is a compilation of a few COVID resources that are available, which have been created over the past few months to help communities in finding the care that they need. So we have a testing locator, we have information about post-COVID-19 care clinics, and vaccine information. And the last option here is the monoclonal antibody treatment information. So if you click on that, you're directed to this treatment sites page, which allows you to locate sites that offer the monoclonal antibody treatments, again, in the downstate New York region. So we've provided some background information here, and if you just wanted to show an overview, so we have 8 different regions included on this page, so the 5 New York City boroughs, Long Island, Nassau, and Suffolk, and Westchester. And currently we have 26 different sites listed on the website. So before I go into a few examples, I just wanted to show these 3 filters at the top. So in our communication with the various sites, we found that there's some information that is really important, again, for both patients and providers to know. So we've highlighted those in each entry. And those 3 are Edie Walk-Ins, Self-Referrals, and On-Site Testing. So for Edie Walk-Ins, we have a few sites that allow patients to walk into the ED while others require scheduling an appointment ahead of time. We have some sites that allow patients to self-refer, whereas others require a patient's provider to refer. And then we have some sites that offer on-site testing if it's needed, whereas others require a patient to bring proof of a positive COVID-19 test with them. So I'll just show you 2 examples. So under the Bronx, we have 2 sites available. The first is Montefiore Medical Center's monoclonal antibody infusion site. So for each site, we have the name of the site, the address. This icon on the right of the address will direct you to Google Maps. Then we have a phone number or a website listed if they were able to provide one. And then the next line shows the 3 features that I mentioned earlier, Edie Walk-In, Self-Referrals, and On-Site Testing. And we've used either a green check or a red X to indicate if that facility has that feature available. So in this case, Montefiore's infusion site does allow Edie Walk-Ins and has on-site testing, but does not allow for self-referrals. So looking at the referral and scheduling information, We've listed that patients seeking treatment can walk into the ED, and providers seeking to refer a patient can email the email address listed here. And I just wanted to go over 2 more examples. So we have a number of H&H sites, facilities listed on this directory. This one here is Jacoby's site. In this instance, they do not allow ED walk-ins, but they do allow self-referrals. So in their referral and scheduling information, we've listed that the patient must schedule a virtual visit at expresscare.nyc, and visits are available 7 days a week. And then the last sort of entry I wanted to show you is SUNY Downstate listed here, which does not allow for ED walk-ins or self-referrals. So we've indicated that a provider referral is required for treatment at this facility. So those are just a few examples I wanted to share. At the bottom of the page, we have 3 links here which allow you to access treatment sites outside of the downstate New York region. And then when I hover back up to the navigation pane on the left side, we also have a resource library. So this contains various fact sheets and guidance for both patients and providers that you may need to disseminate to folks that may need additional information about the treatments. And then we have some information about treatment costs and reimbursement information for providers. So we'll be updating this site frequently, both the resource library and the locator. So we'll make changes to sites if updates are needed, and we'll also add new entries as additional sites become available. So I know we're 10 minutes over. I'm happy to take any questions if there's time. Thank you.
Hi, thank you so much, Faiza. If somebody wants to be listed as a treatment site, where should they reach out to, or is there an email or?
Sure. No, that's a great question. Yes, you can reach out to myself or my colleague, Amy Chin. So Mary, maybe you can distribute my email out to the group here. And we will make sure that we get that on this website as well for sites that may want to add themselves on this list.
Do we want to do a couple of questions? Maybe 1 or 2, or should we save those for next time?
Yeah, I think there's just maybe one good question that came up that I wish we had time to talk about the variants and the impact they might have with the effectiveness of monoclonal antibody therapy. So I was wondering if Elizabeth could give a quick response.
Hi. Yeah, so they have been asking if the monoclonal antibodies have been shown to be effective against the variants. So some preliminary results published in a preprint by one this year, at the beginning of the year, have shown that all the monoclonal antibodies are effective against the quoting UK variant, but also the Regeneron cocktail retain activity against the B135, the one that was first isolated in Brazil, and as it is expected to be also effective against the Brazilian variant, the P1, because the mutations in the receptor binding domain are shared between the 2 variants. But more resources, more studies will be coming up studying the effectiveness, and also Regeneron and Eli Lilly are investigating other monoclonal antibodies to be effective against the variants, the mutations. So more to come.
Great. Thank you so much, Ellie. I just, in the interest in respecting everyone's time, apologies for running over, but thank you to those that were able to stay on with us. And as mentioned, we are going to be very quickly, hopefully soon, coming out with a Dear Colleague letter with a lot more detailed information on the therapies. But I think all the resources listed here should get you to a good start. And we thank our partners at Greater New York for all the amazing work they've done to put these resources together. So we encourage you to use it in support of your high-risk patients. And please help us try and get the word out. And we'll also be very shortly posting a patient information handout on our provider website. So please keep an eye out for that. But thank you all, as always, for your work that you do to support New Yorkers getting through this pandemic as safely as possible. And we will hopefully see most of you in 2 weeks. Thank you, everyone, for joining. And have a great, safe weekend.